Okay. Hello, everyone, and welcome to this webinar about the most challenging cases in pediatric oncology. My name is Sofia, and I'm a pediatric surgeon in Portugal. I am very pleased to welcome our young investigator who will be presenting today's case. Anna Campello is a pediatric resident at the Department of Pediatric Oncohematology in Regina Margherita Children's Hospital in Turin, Italy. Her main fields of activities are sarcomas and rare tumors, and she has been involved in research studies that explore the genomic profiles of sarcomas. Welcome, Anna. And I'm also very pleased to welcome our expert for today, Dr. Marjolijn Jongmans. Dr. Jongmans is currently a consultant in clinical genetics in Radboud UMC and is also affiliated with the UMC Utrecht Prinses Maxima Center for Pediatric Oncology in the Netherlands. Her topic of expertise is diagnostics and counseling of children with cancer predisposition syndrome. She is also a co-principal investigator in the CUPIR group with a focus on identification of novel childhood cancer predisposition genes and description of the corresponding phenotypes. And in November 2013, she defended her PhD thesis entitled Improving the Clinical and Molecular Recognition of Pediatric Cancer Predispositions. Dr. Jongmans, we are very honored to have you here today as an expert to comment on this case. So, today's webinar is called Adrenocortical Carcinoma with Brain Metastases in a Child with Beckwith-Wiedemann Syndrome. Let me just remind you that please write your questions in the question box and we will discuss them after the presentation. And now, without further ado, please, Anna, the audience is yours.
Thank you for this incredible opportunity. And next slide. We have both nothing to declare. Next, please. Okay, so I'm glad to report to you the clinical history of a child diagnosed with Beckwith-Wiedemann syndrome when he was 2 months old. At birth, the newborn showed macroglossia, left ear crease, and umbilical hernia, clinical features consistent with Beckwith-Wiedemann syndrome. And in fact, 2 months later, the genetic analysis revealed a mosaic loss of methylation of the maternal imprinting center 2, IC2, at the chromosomal region 11p15.5, one of the most frequent causes of this syndrome. Next, please. A first abdominal ultrasound performed at birth just before the genetic result showed a congenital left adrenal cyst with a diameter of 1 centimeter. Urinary catecholamines and their metabolites, homovanillic acid and vanillamandelic acid, were negative. Next, please. So, although the international recommendations suggest that patients with loss of methylation at the EC2 should not routinely undergo ultrasound surveillance because the tumor incidence is lower than other molecular subgroups, since the presence of this adrenal cyst, it was decided along with the family to monitor the child with an abdominal ultrasound every 3 months. Our decision was based also on these American recommendations showed on the left for the management of the adrenal masses in Beckwith-Wiedemann syndrome. Next, please. But after 3 months, the adrenal cyst showed increased dimension, as you can see, with a diameter of 3 centimeters, hypoechoic features with vascular spots seen in Doppler mode. Moreover, high levels of plasma metanephrines and norepinephrines were found. So next slide, first question for the audience. What would you do next? Would you perform a biopsy for histological confirmation, an abdominal CT or MRI, or MIBG scintigraphy? Well, okay. The most of you would perform an abdominal MRI. Next slide. Actually, there is not the right answer. We decided to perform an MIBG scintigraphy, and it was completely negative. Anyway, following these recommendations, whole body MRI or CT wouldn't be incorrect at all. Next slide, please. So the patient continued his follow-up with an abdominal ultrasound, alpha fetoprotein levels measurements, the latter just for research purpose, and endocrinologic visits every 3 months. The adrenal cyst had been stable in size for 2 years, and plasma levels of metanephrines and norepinephrines returning to normal range. Next, please. But at 3 years old, at a scheduled medical examination, the patient showed a precocious puberty with pubic hair and larger testicles and penis. The abdominal ultrasound showed increased dimension of the known adrenal cyst with a size of 4 cm per 3 cm, with solid components inside, as you can see. Next slide. So always according to these recommendations, first we performed a thoracoabdominal CT scan that confirmed the presence of a solid mass in the left adrenal gland and no other pathological findings. Second, urinary catecholamines, plasma metanephrines, and norepinephrines were negative, but serum high level of dihydroepiandrosterone and testosterone was found. So next slide and next question for the audience. In your opinion, what's the most likely diagnosis? Neuroblastoma, neuroendocrine tumor, adrenocortical tumor, or fulcrumcytoma? Well, correct. High level of dihydroepiandrosterone and testosterone, along with precocious puberty, are made the suspicion of a malignant adrenocortical tumor very high. Next slide. Thus, we used the European expert partner diagnostic recommendations to stage the patient. So a PET scan was performed and showed a small increase and heterogeneous uptake of the known adrenal mass without other findings. A brain MRI was also performed, and next slide. Surprisingly, it showed multiple small enhancing nodules with very little perilesional edema. The bigger one had a size of 1 centimeter. In some of these, a thin vascular structure starting from the lesion was recognized, raising in our team the question whether these lesions could be metastases from the adrenal tumor or just simply brain vascular malformations. Next, please. The patient underwent open left adrenalectomy with complete resection and no tumor rupture, followed by a normalization of plasma dihydroepiandrosterone. Histological diagnosis of adrenocortical neoplasm was made with a Wernicke score of 2 due to prominent vascular and capsular invasion. So according to the Wernicke index, the patient could be assigned to the group of benign tumors with a good prognosis. But what about the brain lesions? So next question for the audience, I'm asking you, what would you do with the brain lesions? Would you perform just only observation or a biopsy for histological confirmation, or would you propose to the patient the surgical removal of all the lesions? Okay, well, actually, there is not the right answer also in this case. Actually, it was not easy at all for us. Next slide, please. Actually, after multidisciplinary discussion, the patient underwent a brain biopsy, as most of you would have done, and the metastatic nature of the brain lesions was confirmed. So according to the European expert guidelines, 6 cycles of adjuvant chemotherapy with etoposide, doxorubicin, and cisplatin, along with mitotan, were administered without significant toxicity. An NGS assay was performed within a clinical study and showed 2 mutations in the CTNNB1 and GNAS gene. Both the mutations have been previously described in adrenal tumors. At the end of the treatment, no abdominal relapse was identified, and the last brain MRI, performed just 1 month ago, showed stability of the brain lesions. Unfortunately, brain surgery was considered not feasible due to the high number of the lesions. But next question for the audience. What do you propose to the patient about the brain metastasis? So would you propose a strict follow-up, a whole brain radiotherapy, stereotactic radiosurgery, or other chemotherapy cycles, or new drugs? Okay, well, actually, stereotactic surgery and new drugs are the winner answers. If we can come back to the next slide. Again, it was not easy at all for us to choose, and unfortunately, there is not the right answer. Actually, brain metastases are extremely rare in adrenal carcinoma, and the right management is still unknown. The current situation is that the patient has just finished his treatments, and what we have decided among our team is to continue mitotan up to 2 years from diagnosis, to perform abdominal ultrasound, brain MRI, and chest X-ray every 3 months, and to propose a radiosurgery in case of an increase in size of 1 or more brain metastases. We do not propose whole brain radiotherapy due to the young age of the patient. And unfortunately, the 2 somatic mutations found are not pharmacologically targetable. Next slide, please. So we have thought that this case is interesting for 2 main reasons. The first explores the Wernicke score prognostic value, and the second one concerns the tumor surveillance strategies in children with Beckwith-Wiedemann syndrome. Next slide, please. So why there is still need to talk about the Wernicke score? Because histological features are used to classify pediatric adrenocortical tumors as adenomas or carcinoma, but the histopathologic distinction between these 2 subtypes can be quite often difficult. In pediatric disease, the Wernicke criteria are the most commonly used for risk assessment, but this score has shown to be predictive of patient outcomes when score is banning, so with a score under 3, not in the case of the malignant subgroup. In fact, it has been demonstrated that a high proportion of children in the malignant subgroup have actually a benign outcome. Anyway, this was not the case of our patient, where surprisingly a benign score was associated instead with a metastatic tumor. Altogether, these considerations highlight the inability of the Wernicke score to predict malignancies with strong reliability. Recently, a 5-item score by Picard and her team has been proposed, but its utility has to be still ruled out. Anyway, in our case, it would be useless to predict the stage of our patient as well. Next slide, please. In the era of precision medicine, next-generation sequencing and new molecular findings may offer in the future new opportunities to improve tumor stratification and maybe to help in guiding therapeutic decision in pediatric adrenocortical tumors. Just to give you an example of this, it has been demonstrated in a pediatric cohort of adrenocortical tumors that patients harboring germline TP53 mutations and somatic ATRX mutation have a really worse outcome compared to other molecular subgroups. Coming back to our patient, I remember you that his tumor harbors 2 somatic mutations previously identified in adrenal tumors. In particular, activating mutations in the CTNNB1 gene encoding beta-catenin are really common and might be associated maybe with a slightly better overall survival. Anyway, at the moment, there is not enough evidence to support tumor testing for somatic mutations to predict the prognosis or treatment. Next slide, please. Second interesting point of discussion is the tumor surveillance strategies in patients with Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome is a tumor predisposing syndrome for some solid tumors. First of all, Wilms tumors, hepatoblastoma, but also neuroblastoma, rhabdomyosarcoma, and adrenocortical carcinoma, of course. There is no generally accepted risk threshold for performing tumor screening strategies. In fact, although in the USA screening is considered for a tumor risk upper 1%, in Europe a risk of 5% is usually considered an appropriate threshold. In the international recommendation, screening is suggested to be stratified according to the genotype. So since EC2 loss of methylation patients have usually a lower tumor incidence than other molecular subgroups, with an overall tumor risk lower than 3%, the recommendations suggest that this subgroup should not routinely undergo tumor surveillance. Next. Various protocols have been suggested for tumor surveillance in Beckwith-Wiedemann syndrome, usually comprising abdominal ultrasound with or without measurement of alpha-fetoprotein levels, mainly for Wilms tumors and hepatoblastoma screening. Adrenal carcinoma is rare in Beckwith-Wiedemann syndrome, and to date there is no data on the utility of screening strategies. Anyway, in some cases series, adrenal masses as a cyst or adenoma are described as common findings in patients with Beckwith-Wiedemann syndrome. The exact frequency is unknown, but since the high rate of these findings, recommendations of the management of adrenal masses have been recently published. The most important thing that we have to take in mind is that there should be a low threshold for investigation in response to new symptoms, as precocious puberty in our patient. Next slide. And last question for the audience, just to keep the audience awake. Do you know how tumor surveillance is scheduled in your centers for patients with Beckwith-Wiedemann syndrome? Okay, well, with this answer, I let the experts speak.
Yes,
thank you,
Anna.
Anna.
Thank you very much. Thank you for this very interesting but also very exceptional case. I think many rare events followed each other in this child. And the danger of such a case, because these are often also the patients that end up in publications and case reports. And of course, that's important because we can learn a lot from such cases. But if you look at surveillance protocols, then it's important to have a look at large groups of patients and indeed calculate the risks. because you make an advice for the group as a total. And indeed, more and more, even we can separate the syndromes by genotype-phenotype correlations into different risk groups. So that was clearly the case in Beckwith-Wiedemann syndrome. And we do know that the children with the specific molecular subtype that your patient was in, that group has a very low tumor risk. But we do know that it once in a while occurs. But if you think of surveillance protocols, then this of course has an impact for parents. On one hand, it can be very reassuring to get this monitoring. But on the other hand, it can also be anxious around each screening episode. So it also gives stress. And then, of course, there is the problem of false positive findings. So if you screen all these children with low risks, then likely you will find more children with cysts or other lesions that in the end don't really matter. And these children might end up having surgeries or biopsies. And of course, then in the end, the parents are reassured, but we did affect the child by medical interventions. And Beckwith-Wiedemann is frequent. So this affects quite some children, but that also means that we can calculate the numbers. But for many conditions, that is still not possible because the numbers are so low. And actually, we also don't know what the benefit is of screening for adrenocortical cancer, because that is so rare. Because another very important thing to take into account when you think about surveillance is that you really want to make a difference. The purpose is not to find the tumor, but to change the outcome of the cancer. And for adrenocortical cancer, the numbers are so low that it's hard to compare a group that did have surveillance and a group that didn't. But taking that all into account, these international groups came up with this surveillance protocol, and it's I don't know whether it is surprising, but the answer to your question shows that still people are quite defensive and still often opt for surveillance. And maybe we should investigate that a bit more, do more of such questionnaires throughout Europe, and also ask why people stick to screening in such cases.
Anna and Dr. Jongmans, thank you so much for your contribution. We currently don't have any questions from the audience, so maybe I will ask you, Dr. Jongmans. This case really, as Anna showed us, it revealed a very big mismatch between the histological score that we currently use, which is Wernicke score, and the malignancy per se of the tumor. Do you think that maybe genetics will play a role on classifying tumors in the future as benign or malignant instead of histology?
Yeah, of course, in the Princess Maxima Center, we have quite large numbers at all the multidisciplinary meetings. And there I observe this quite often, that the pathologist is surprised that poor prognostic mutations are found, whereas while he or she is looking through the microscope, is thinking that is looking at a low-grade tumor. So yes, this is very informative, and this might also change the field of surveillance, because if you could surveil these children by liquid biopsies, then with one test you could screen for all the different tumors, and also immediately you could pick up mutations that show that the tumor that is there is also a poor prognostic tumor. But of course, there's still much to learn about all the different mutations in the different cancers. But yes, that might also make us do biopsies much earlier, because it can then be very informative what the prognosis of the lesion will be.
Okay, thank you so much. Thank you, Anna. Thank you, Dr. Jongmans, for all these amazing presentations. So Anna, please, the last floor is for you.
So next slide with take-home messages. So Beckwith-Wiedemann syndrome is a known predisposing syndrome for adrenocortical tumors. It is rare, but we need to think about it in front of an adrenal mass or a precocious puberty. The case reports and case series showed that brain metastases are extremely rare in adrenocortical carcinoma, and the correct management is still unknown. Since the rarity of adrenocortical carcinoma, the biologic behavior of these tumors is difficult to predict, and histopathologic classification criteria have a limited role in guiding therapeutic decision, as we have seen with the prognostic value of the Vinica score. And maybe in the future, incorporating molecular data will maybe help stratify and improve outcomes in patients with adrenocortical carcinoma. And next slide with a big thank you.
Thank you, both of you again, and thank you for all the audience. We hope you enjoyed this webinar and hope to see you on the next one only in September. Next webinar will be in September. So thank you, everyone.
Thank you.
Yes, thank you both. Have a nice evening.